light stimuli, go through the refractive media of the eye, and reach the retina. In the retina, light stimuli produce physical and chemical alterations in the retinal receptors. In turn, these alterations provoke physicochemical and electrical changes that are transmitted to the central nervous system. Eventually, visual sensations of form, spatial relationships, and color appear in our consciousness. The events in the sensory aspect of the visual process precipitate a chain of responses in the inner and outer muscles of the eyes. The tasks of the motor system of the eye: 1. To enlarge the field of view by transforming the field of vision into the field of fixation. 2. To bring the object of attention onto the fovea. 3. To position the two eyes in such a way that they are properly aligned, thereby ensuring a single binocular vision. Voluntary eye movements are willed by the individual, as a result of a chain of impulses that originate in the cortex. Involuntary eye movements are not willed by the individual and occur without awareness. Examples of involuntary eye movements: when the illuminance of the retina changes, the pupil of the eye constricts or dilates. When we tilt our head to one shoulder, the eyes rotate around their anteroposterior axis in the direction opposite that of the head. When a light stimulus reaches the retinal periphery, the eye turns and causes the stimulus to impinge on the fovea. If a binocularly fixated object approaches the eyes, the visual axes converge to maintain fixation. Let us position an object in front of an observer at the eye level and in the midplane of the head. If the eyes are properly aligned and the object is fixated binocularly, an image will be received on matching areas of the two retinas. If the two eyes are functioning normally, the two images will be in the same size, luminance, and color. In spite of the presence of two retinal images, only one visual object is perceived by the observer. Whenever a retinal area is stimulated by an image, the image is perceived as being localized in a certain direction in the visual space. If the stimulated retinal area is located to the left of the fovea, the object is seen in the right half of the field. If it is located to the right of the fovea, it is seen in the left half of the field. The appearance of an object in the periphery of the visual field attracts attention, and the eye is turned toward the object so that it will be imaged on the fovea. A signal from the retinal periphery transmits to the brain the peripheral direction of the object. Corresponding impulses are then sent to the extraocular muscles to perform the necessary ocular movement needed to put the image onto the fovea. Each retinal element has a retinomotor value. This retinomotor value of the retinal elements increases from the center toward the periphery. The retinomotor value of the fovea itself is 0. The fovea is the retinomotor center, or the retinomotor 0 point. The retinomotor value makes it possible to measure ocular deviations by means of the prism and covert test. Corresponding retinal elements are those elements of the two retinas that give rise to the sensation of the same visual direction. Sensory correspondence is the unification of visual excitations of the two corresponding retinal images into a single visual image. The simultaneous stimulation of non-corresponding retinal elements by an object causes this object to be localized in two different visual directions and appears double or in diplopia. Motor fusion is the ability to align the eyes to allow the sensory fusion to be maintained. The stimulus for the motor fusion is retinal disparity outside Panem's area. Motor fusion is the exclusive function of the extrafoveal retinal periphery. In motor fusion, the two eyes are moving in opposite directions. When dissimilar images are presented to corresponding retinal areas, fusion becomes impossible. This phenomenon is termed binocular rivalry. Binocular rivalry may be produced by different color and unequal luminance of the two targets. Simultaneous stimulation of corresponding retinal areas by dissimilar images gives rise to conflict and confusion. One of the two images is temporarily suppressed. The horopter is the locus of all object points that are imaged on corresponding retinal elements. Panem's area of single binocular vision is a narrow band around the horopter. In Panem's area, stimulation of disparate retinal elements transmits the impression of single vision. Put your finger at reading distance in front of your head, and in its midplane. Select an object at infinity in the line with your finger. Fixate the more distant object. Your finger will be seen double. Fixate your finger. The more distant object will be seen double. This is a physiologic diplopia. Stereopsis is the relative ordering of visual objects in depth, that is, in the third dimension. Object points having a constant size appear to subtend smaller and smaller angles as they recede from the subject. Configurations in which contours are interposed on the contours. An object that interrupts the contours of another object is generally seen as being in front of the object with incomplete contours. Since sunlight comes from above, we have learned that the position of shadows is helpful in determining elevations and depressions, that is, the relative depth of objects. If the size of two objects is known, one can judge the relative distance of these objects by their apparent size. In humans there are 3 pairs of extraocular muscles in each orbit. A pair of horizontal rectus muscles. A pair of vertical rectus muscles. And a pair of oblique muscles. The 4 rectus muscles come from the depth of the orbit and are attached to the sclera anterior to the equator. The 2 oblique muscles come from in front of the orbit, at the medial side, and are attached to the sclera posterior to the equator. Contraction of the rectus muscles pulls the globe backward and nasalward. Contraction of the oblique muscles pulls the globe forward and nasalward. There are 4 rectus muscles in each eye. The medial rectus, the lateral rectus, the superior rectus, and the inferior rectus muscles. The 4 rectus muscles, the superior oblique muscle, and the levator palpebrae superioris muscle have an origin in a circular fashion called the annulus of Zinn. The annulus of Zinn is an oval opening surrounds the optic canal, and a part of the superior orbital fissure. Structures pass through the annulus of Zinn are the optic nerve, the ophthalmic artery, and parts of cranial nerves 3 and 6. The superior rectus muscle is separated from the roof of the orbit by the levator muscle of the upper lid. About 10 mm posterior to the equator, the 4 rectus muscles curve abruptly toward the globe at the muscle pulleys. The insertions of the rectus muscles lie on a spiral, the spiral of Tillaux. The insertion of the medial rectus muscle is the closest to the corneal limbus, followed by the inferior rectus, the lateral rectus, and the superior rectus insertions. The length of the 4 rectus muscles is fairly constant, about 40 mm. There are variations of the length of tendon of the different rectus muscles. The longest is the lateral rectus muscle tendon, while the shortest is the medial rectus muscle tendon. The superior oblique muscle has its origin above and medial to the optic foramen. It courses parallel with the medial orbital wall, and reaches the trochlea at the angle between the superior and medial orbital wall. After passing the trochlea, the superior oblique muscle turns in to form an angle of 54 degrees with the direct portion of the muscle. 10 mm behind the trochlear, the muscle becomes tendinous. The tendon passes under the superior rectus muscle, fans out, and merges laterally. The length of the direct part of the superior oblique muscle is about 40 mm, the length of the reflected tendon is about 19.5 mm. From a physiologic and kinematic standpoint, the trochlear is considered the true origin of the superior oblique muscle. The inferior oblique muscle is the shortest of all the extraocular muscles, being only 37 mm long. The inferior oblique muscle arises from a shallow depression in the bony orbit in the orbital plate of the maxilla, near the entrance of the nasolacrimal canal. The inferior oblique muscle courses backward, and laterally, between the floor of the orbit and the inferior rectus muscle. It inserts in the posterior and external aspect of the sclera. The inferior oblique muscle is almost wholly muscular. The eyeball is suspended within the orbit by a system of fasciae. The bulk of the system is made up of Tenon's capsule. The extraocular muscles pierce Tenon's capsule to enter the subcapsular space, and insert into the sclera. Therefore, one can distinguish an extracapsular portion and an intracapsular portion of each muscle. In their extracapsular portions, the extraocular muscles are enveloped by the muscle sheath. The muscle sheaths of the four rectus muscles are connected by the intermuscular membrane. The muscle sheath of the superior rectus muscle adheres to the muscle sheath of the levator palpebrae superioris muscle. The fusion of these two muscle sheaths accounts for the elevation of the upper lid on elevation of the eye. The blending of the sheaths of the inferior oblique and inferior rectus muscles and the extensions of the sheaths of the medial and lateral rectus muscles form a suspending hammock, which supports the eyeball. This fascial system has been termed the suspensory ligament of Lockwood. The medial and lateral rectus muscles possess fibrous membranes called the check ligaments. The check ligaments extend from the outer aspect of the medial and lateral rectus muscles to the corresponding orbital wall. Innervation of extraocular muscles. The medial rectus, the superior rectus, the inferior rectus and the inferior oblique muscles are all innervated by the cranial nerve 3, the ocular motor nerve. The branches of the cranial nerve 3 enter their respective muscles from the bulbar side. The lateral rectus muscle is innervated by the cranial nerve 6, the abducens nerve. The cranial nerve 6 enters the muscle from the bulbar side. The superior oblique muscle is innervated by the cranial nerve 4, the trochlear nerve. The cranial nerve 4, the trochlear nerve, enters the muscle from the outer orbital side. All the extraocular muscles are supplied by the lateral and medial muscular branches of the ophthalmic artery. The arteries to the four rectus muscles give rise to the anterior ciliary arteries. There are two ciliary arteries emerge from each tendon, except for the lateral rectus muscle, which has only one artery. The anterior ciliary arteries pierce the sclera near the corniscleral limbus. The anterior ciliary arteries anastomose with the lateral and medial long ciliary arteries to form the major arterial circle of the iris. The veins from the extraocular muscles correspond to the arteries and empty into the superior and inferior orbital veins. The eye performs rotary movements around a center of rotation located 13.5 mm behind the apex of the cornea. The eyeball can rotate around one of three axes: the anteroposterior, y-axis, the vertical, z-axis, and the horizontal, x-axis. Listing's plane is a plane passes through the center of rotation and the equator of the globe. The vertical and the horizontal axes of rotation lie in listings plane. Rotations around the vertical axis are called adduction and abduction. Rotations around the horizontal axis are termed elevation and depression. Rotations around the anteroposterior axis are known as excycloadduction and incycloadduction. The primary position is assumed by the eye when one is looking straight ahead with body and head erect. The adducted, abducted, elevated, or depressed positions of the globe are designated as secondary positions. The oblique positions of the eye are termed tertiary positions. Contraction of one of the horizontal rectus muscles produces a pure rotation around the vertical axis. The lateral rectus muscle produces abduction, and the medial rectus muscle produces adduction. When the eye is in primary position, the actions of superior rectus muscle are elevation, adduction and incycloadduction. If the globe is abducted 23 degrees, its axis of rotation approaches the x-axis. At that moment the superior rectus muscle becomes a pure elevator. If the globe is adducted 67 degrees, the superior rectus would produce pure incycloadduction. When the eye is in primary position, the actions of inferior rectus muscle are depression, adduction and excycloadduction. If the globe is abducted 23 degrees, its axis of rotation approaches the x-axis. At that moment the inferior rectus muscle becomes a pure depressor. If the globe is adducted 67 degrees, the inferior rectus would produce pure excycloadduction. In primary position the superior oblique muscle causes incycloadduction and depression of the eye, and also acts as an abductor. When the globe is adducted 54 degrees, the superior oblique muscle acts as a pure depressor. When the globe is abducted 36 degrees, the superior oblique muscle would produce pure incycloadduction. In primary position the inferior oblique muscle causes excycloadduction and elevation of the eye and also acts as an abductor. When the globe is adducted 54 degrees, the inferior oblique muscle acts as a pure elevator. When the globe is abducted 36 degrees, the inferior oblique muscle would produce pure excycloadduction. Donder's and Listing's laws. Each one of the extraocular muscle is regarded as an independent mover. Every contraction of a muscle brings a movement. The mover muscle which is producing that movement is called the agonist. A movement in the direction opposite that produced by the agonist is caused by its antagonist. Thus, the medial rectus muscle and the lateral rectus are antagonists. Two muscles moving an eye in the same direction are synergists. For example, the superior oblique muscle and the inferior rectus muscle are both depressors of the eye. Thus, they are synergists. Synergistic muscles in the two eyes that cause the two eyes to move in the same direction are known as yoke muscles. Thus, the right medial rectus and the left lateral rectus muscles cause levoversion of the eyes. They are yoke muscles. Sherrington's law of reciprocal innervation stated, whenever an agonist receives an impulse to contract, an equivalent inhibitory impulse is sent to its antagonist to relax. Herring's law of equal innervation stated, whenever an impulse for the performance of an eye movement is sent out, corresponding muscles of each eye receive equal innervations to contract or relax. When an observer binocularly fixates an object, when the object approaches the observer's head, the eyes must increase their refractive power to produce a well-focused image of the approaching object. At the same time, the angle between two visual axes must increase to allow the object's images to remain on the two foveae. The opposite process takes place when an object recedes from near fixation. The refractive power of the eyes is altered to ensure a clear retinal image. This process of changing the refractive power of the eye is known as accommodation. The change in the relative position of the visual axis is known as convergence when the angle formed by the visual axis increases, and is called divergence when the angle formed by the visual axis decreases. In addition, with fixation at near vision, pupillary constriction occurs. The near vision complex is the association of accommodation, convergence, and pupillary constriction during fixation at near. Accommodation is measured in diopters. If the fixation distance is 1 meter, the accommodation is 1 diopter. If the fixation distance is ½ meter, the accommodation is 2 diopters. If the fixation distance is 1/3 meter, the accommodation is 3 diopters, and so forth. The near point of accommodation, NPA, is the near fixation distance inside which the eyes cannot accommodate. The far point of accommodation, FPA, is the distance from infinity to the near point of accommodation. The range from infinity to the near point of accommodation is the range of accommodation. The distance of the near point, and therefore the range of accommodation, is a function of advancing age. The meter angle is the amount of convergence required to fixate an object located at 1 meter from the eyes. If the fixation distance is 1 meter, an emmetropic subject must converge 1 meter angle, and accommodate 1 diopter. If the fixation distance is ½ meter, an emmetropic subject must converge 2 meter angle, and accommodate 2 diopters, and so on. Accommodative convergence to accommodation ratio AC to A ratio. When a person exerts a certain amount of accommodation, a determined amount of convergence is elicited. The convergence so elicited is called accommodative convergence. Therefore, a normal, emmetropic person should be expected to exert 1 meter angle of convergence for each 1 diopter of accommodation. The convergence response to a unit stimulus of accommodation may be expressed by accommodative convergence to accommodation ratio, AC to A ratio. The extraocular muscles can be divided into 2 distinct portions. One portion is a peripheral orbital layer along the muscle surface and faces the orbit. This layer encloses a second portion, the central or bulbar layer, close to the globe, which consists of thicker muscle fibers. The rectus muscles insert in a bifid fashion. The global layer terminates at the myotendinous scleral insertion, whereas the orbital layer branches off further posteriorly to insert at the pulleys. The ratio of nerve fibers to muscle fibers is nearly 1:12 in extraocular muscles, whereas in skeletal muscles it may be as high as 1:125. This abundance of nerve fibers has led to the conclusion that the all-or-nothing law, or law of isobolia, applies to eye muscles. According to this law, individual muscle fibers respond with the maximum contraction to every supraliminal stimulus. Extraocular muscles also are provided with 3 types of nerve endings: ordinary single motor end plates, multiple grape-like nerve endings around the tendons, and very fine, non-medullated fibers ending in the thinner muscle fibers. Electromyography responses have been recorded from extraocular muscles. Electromyography has proved to be of value in assessing paratic and pseudopratic conditions of extraocular muscles, in myopathies, and in elucidating the pathophysiology of the retraction syndrome. Simultaneous electromyography of the 4 rectus muscles showed the graded increase in electrical activity in the right medial and left lateral rectus muscles with corresponding decrease in activity in the right lateral and left medial rectus muscles as the eyes perform a levoversion movement. With return to the primary position, the right lateral rectus and the left medial rectus resume their activity and increase it in the ensuing dextroversion, while the activity in the right medial rectus and left lateral rectus decreases. Visual acuity is a highly complex function that consists of 1. The minimum visible is concerned with detection of the presence or absence of a visual stimulus. 2. The minimum separable, hyperacuity, concerns the judgment of the location of a visual target, relative to another element of the same target. 3. The minimum resolvable, ordinary visual acuity, is the ability to determine the presence of or to distinguish between more than one identifying feature in a visible target. The visual acuity depends on the location of the retinal stimulus on the retina, and decreases sharply with an increase in distance of the image of an object from the center of the fovea. Visual acuity is poor at scotopic levels where parafoveal or peripheral rod receptors predominate. The pupil size is also involved in the effect of luminance on visual acuity. A large pupil allows more light to enter the eye but increases the effect of the optical aberrations. A very narrow pupil reduces visual acuity by markedly reducing retinal illuminance and by increasing the effect of light diffraction. In general, the visual acuity decreases with reduction in objective contrast. Visual acuity can be reduced by the spatial arrangement of additional contours in the field of vision in amblopic patients. Spectacles have a profound effect on accommodation. For example, a young uncorrected hypermetrope will have to accommodate to see clearly at infinity and correspondingly more for near fixation. If a full correction is worn, the person does not have to accommodate for infinity. On the other hand, an uncorrected myope can do close work without using accommodation. Spectacles lenses with a high refractive correction change the direction in which object points appear in indirect vision. This causes changes in perspective and the perception of space. Spectacles change the size of the retinal image in emmetropic eyes and the blurred image in uncorrected ametropic eyes. In corrected anisomtropia, the retinal images of the two eyes, and consequently the two visual images, differ in size. Neuromuscular anomalies of the eyes can be separated into two main classes. 1. Latent deviations or heterophorias. 2. Manifest deviations or heterotropias. The position assumed by the visual axis when fusion is suspended has been termed the relative position of rest of the eyes. Maintenance of the primary position of the eyes requires the presence of an active continuous tonus of the extraocular muscles. Ideally, the visual lines must be parallel in distance fixation and have the proper convergence in near vision. This is termed orthophoria. Orthotropia is present when a cover test is negative upon covering either eye in all directions of gaze. There are a variety of heterophoric and heterotropic deviations. If the visual axes converge, the condition is called esophoria or esotropia. And if the visual axes diverge, it is known as exophoria or exotropia. Hyperphoria or hypertropia occurs if one visual line is higher than the other. Hyperphoria or hypotropia occurs when the visual line is lower than the other. Cyclotropia is a misalignment of the eyes around the sagittal axis. This produces clockwise or counterclockwise rotations of the globe. Strabismus may occur in one of two major forms. 1. Comitant strabismus, where the deviation is the same in all directions of gaze. 2. Incomitant strabismus, where the deviation varies in different directions of gaze. Strabismus may occur in two forms. 1. Constant deviation as in constant esotropia and constant exotropia. 2. Intermittent deviation as in intermittent esotropia and intermittent exotropia. Esotropia may occur in two forms. 1. Accommodative esotropia. 2. Non-accommodative esotropia. Strabismus may occur in two forms. 1. Unilateral heterotropias, in which the patient habitually uses one eye for fixation, as in right esotropia or left exotropia. 2. Alternating heterotropias, in which the patient fixates with either eye. A deviation noted at birth or in the first months of life is termed congenital. If the deviation rises after that age, it is called acquired. If the action of a muscle is completely abolished, this condition is a paralysis or palsy. If the action of the muscle is impaired but not abolished, this is a pasitis. Neurogenic paralyses of extraocular muscles may be supranuclear, nuclear, or infranuclear in origin. Myogenic paralyses result from diseases of the muscles themselves. Structural alteration of the muscle itself or of its antagonist may limit its ability to function normally. Limitation of eye movements occurs in restrictive, and in paralytic strabismus. Orbital strabismus is caused by anomalies of the orbitor of the face, as in craniofacial dysostoses, plagiocephaly, hydrocephalus, and heterotopia of muscle pull. The relative position of the visual axis is determined by 1. The anatomical factors, which consist of orientation, size, and shape of the orbits, size and shape of the globes, volume and viscosity of the retrobulbar tissue, functioning of the eye muscles as determined by their insertion, length, elasticity, and structure, and anatomical arrangement and condition of fasciae, ligaments, and pulleys of the orbit. 2. The innervational factors, that is, all the nervous impulses that reach the eyes. These factors include the co-movements of extraocular muscles with intrinsic ocular muscles, cycoptical reflexes, fixation reflex, fusional impulses, influences of the static apparatus on extraocular muscles and their tonus, in the lymph, vestibular system, reflexes from neck muscles, and influences of the several nuclear and supranuclear areas that govern ocular motility. Persons can overcome a heterophoria by maintaining a tonus distribution in the extraocular muscles so that their visual axes are parallel for distance, and are properly directed in near vision. This task may cause discomfort symptoms, so-called asthenopic symptoms, or diplopia. What matters is the discrepancy between the heterophoric deviation and the amplitude of motor fusion. If the amplitudes are inadequate to cope with the deviation, asthenopic symptoms may arise. To prevent asthenopic symptoms and diplopia, humans have a built-in mechanism, that is suppression. By suppressing the images from one eye, asthenopic symptoms may be reduced or completely disappear. Estimation of visual acuity in infants. Optokinetic nystigmus is elicited by passing a succession of black and white stripes through the patient's field of vision. The visual angle subtended by the smallest stripe width that still elicits an eye movement, is a measure of visual acuity. Preferential looking. This technique is based on the fact that an infant's attention is more attracted by patterned stimuli than by a homogeneous surface. Visually evoked potentials. A variety of stimuli and recording methods using cortical potentials have been used to assess visual acuity in infants. It has been extremely useful for collecting information on the maturation of visual functions through the visual evoked potentials. Clinically, the tests may establish whether the responses from the two eyes differ. They are also useful for the follow-up of patients with bilateral reduction of visual acuity. Measurement of visual acuity in preschool-aged children. Isolated is. To a preschool child, the E is meaningless, even if it is spoken of by the examiner as an animal with 3 legs. Some has replaced these with the isolated figure of a hand, and in some children this works better than is. Measurement of visual acuity in school-aged children and adults. When testing children of school age and adults, the ophthalmologist may employ any of the systems, charts, and other projection devices, used routinely in the examination of patients. An essential and hardly preliminary part of the examination is determination of the refractive error of the patient. Cycloplegic refraction should be carried out in every patient with strabismus. Fundus examination is an integral part of the refractive procedure but, unfortunately, in some patients, fundus examination and refraction under general anesthesia cannot be avoided. This permits a thorough inspection of the fundus. Inspection of the lids and lid fissures. If the two lid fissures are different in width, the possibility of ptosis or pseudoptosis of the upper lid must be considered. The epicanthus may create the appearance of esotropia or pseudostrabismus. Mongoloid and anti-mongoloid lid fissures are occasionally observed in patients with the A and V patterns of strabismus. The best means of estimating the relative position of the eyes is to have the patient fixate a penlight. If reflected images from the two corneas appear centered, one can assume that the eyes are properly aligned. Unusually narrow interpupillary distance may create the impression that an esotropia is present, while large interpupillary distance may create the impression that an exotropia is present. Facial asymmetries also may create the impression that a hypertropia is present. An angle kappa is caused by failure of the pupillary and visual axes of the eye to coincide. The angle kappa is formed at the intersection of these two axes at the center of the pupil. As a result, when an eye fixates a penlight, the reflection from the cornea will be in a position slightly nasal to the center. This is termed a positive angle kappa. The large positive angle kappa may simulate an exodeviation and produce pseudostrabismus. A negative angle kappa may simulate an essodeviation and again produce a pseudostrabismus. In cases of retinopathy of prematurity, toxocara canis retinitis, or congenital retinal folds, the ectopia of the macula is accompanied by a positive angle kappa. In patients with null-point nystigmus, the patient keeps the head turned to the position where frequency and amplitude of the nystigmus may be reduced, or there may be no nystigmus. Patients who have a high amblyopia of one eye, occasionally tend to turn their head in a direction away from the amblyopic eye. Patients with infantile exotropia manifest latent nystigmus, and strong fixation preference for one eye, often have their face turned toward the side of the fixating eye. Abnormal head positions and incomitant and paitic deviations take either the form of tipping the chin up or down, a head turn, or a head tilt to one shoulder, determination of presence of a deviation. A cover is placed before the eye that appears to fixate. If the patient has a heterotropia and the fixating eye is covered, the opposite eye will make a movement from the heterotropic position to take up fixation, and the covered eye will make a corresponding movement in accordance with Hering's law. If the patient has an esotropia, the uncovered eye will make an outward movement. If the patient has an exotropia, the uncovered eye will make an inward movement. If the patient has a hypertropia, the uncovered eye will make a downward movement, and if the patient has a hypotropia, the uncovered eye will make an upward movement. If there is no movement of the fellow eye, that eye is then covered and the other eye is observed. Once the diagnosis of manifest strabismus has been made, it is possible to establish the degree of the fixation behavior. In the case of monocular fixation, the just uncovered eye will immediately resume fixation as the fellow eye returns to its deviated position. As is seen in uniocular esotropia, uniocular exotropia, uniocular hypertropia, and uniocular hypotropia. In the case of alternating fixation, the formerly deviated eye will continue to fixate after removal of the cover. As is seen in alternating esotropia, alternating exotropia, and in alternating hypertropia. The cover-uncover test may also determine whether the patient has a latent deviation. One eye and then the other is covered while the patient maintains fixation. The examiner directs attention to the covered eye just as the cover is removed. If the patient has a heterophoria, the covered eye will deviate in the direction of the heterophoric position. When the eye is uncovered, it will move in the opposite direction to re-establish binocular fixation. The possible results of the cover and cover-uncover tests may be summarized as follows. First, uncovering the seemingly fixating eye. If there is no movement of the other eye, then there was binocular fixation before applying the cover. But, if there is movement of the other eye, then a manifest deviation was present before applying the cover. Second, on uncovering the eye. If there is movement of the uncovered eye and no movement of the other eye, then a heterophoria is present. But if there is no movement of either eye, the uncovered eye deviated, and the opposite eye continues to fixate, then an alternating heterotropia is present. Third, on uncovering the eye. If the uncovered eye makes movement and assumes fixation, the opposite eye deviates, then, a unilateral heterotropia is present. Finally, if the fixating eye is covered, the deviated eye will make no movement, then an eccentric fixation is present. When the cover test is applied to the fixating eye in a strabismic infant and the other eye performs searching, nystagmoid movements, then chances are high that visual acuity of that eye is low and amblyopia must be suspected. The cover test is also helpful in diagnosis of a pseudoptosis. If pseudoptosis is present, it will disappear when the fellow eye is covered. A clinically useful modification of the cover test was introduced by Spielman. By using the Spielman occluder, the diagnosis of heterophoria is simplified because the deviation of the covered eye can be observed by the examiner without having to remove the cover. Covering both eyes with translucent occluders permits a quick preliminary determination of whether an esotropia is accommodative or non-accommodative. In accommodative esotropia, the eyes will straighten after covering both eyes, while in non-accommodative type, the esotropia will persist. Tests used to measure the deviation are classified into two major types, objective and subjective tests. Objective tests. Prism and cover test. Principle of the prism and covert test. In case of heterotropia, when a cover is placed in front of the fixating eye, the deviated eye makes a movement in a direction opposite that of the deviation. A prism is placed in front of the deviated eye. The power of the prism required to offset the movements is a measure of the deviation. The prism is placed in front of the deviated eye according the rule of bad, or base against deviation. To measure an esotropia, the prism is placed base out, for an exotropia base in, for a hypertropia base on, and for a hypotropia base up. The prism strength is increased until the movement is offset. The power of the prism required to offset the movements is a measure of the deviation. Measurement with the Major Ambleroscope. The deviation is measured by moving the arms of the Major Ambleroscope into such a position that images of the target fall on the respective foveal areas. Corneal reflection tests, Hirschberg test. Hirschberg found that each 1 mm of decentration of the corneal reflection corresponded to 7 degrees of deviation of the visual axis. With a millimeter ruler, one can measure the displacement of the corneal light reflection that occurs in the deviated eye. The linear displacement of the reflection is then converted into angular values. Krimsky test. Prisms are placed in front of the blind deviated eye till we center the corneal reflection on this deviated eye. The amount of prism power necessary to achieve this is the measure of the deviation. Modified Krimsky test. The angle of deviation is the amount of prism power that causes a movement in the normal eye necessary to centralize corneal reflex in the deviated eye. Bruckner test. A bright coaxial light source emitted by a direct ophthalmoscope illuminates both eyes of the patient simultaneously from a distance of 1 meter in a semi-darkened room. The position of the corneal reflection and differences in the brightness of the fundus reflex between the two eyes are noted. In the presence of strabismus, the reflex of the fixating eye is darker than in the deviated eye. Ophthalmoscopy and fundus photography. Indirect ophthalmoscopy and fundus photography are useful auxiliary methods to diagnose and measure the amount of cyclotropia. Subjective tests, Diplopia tests. The principle of Diplopia tests is to dissociate between the two visual fields by different methods, as to place a red glass is in front of one eye, and a green glass in front of the other eye. The dissociation between the two visual fields will differentiate the two visual images. In case of orthotropia, the two visual images will be superimposed. But in case of heterophrenia or heterotropia, the two visual images will be seen double. The distance between the two images is the amount of the deviation. Red glass test. A red glass is placed in front of one eye. The patient fixates a small light source and states whether the red light is to the right or to the left and above or below the white light. In orthotropia, the red and the white lights are superimposed. In esotropia, the image of the fixation point in the deviated eye falls on a retinal area nasal to the fovea. There should be uncrossed diplopia of the red and the white lights. In exotropia, the image of the fixation point in the deviated eye falls on a retinal area temporal to the fovea. There should be crossed diplopia of the red and the white lights. The Maddox cross test. If the white fixation light is in the center of a Maddox cross, the patient must state the number near which the red light is seen. This number indicates the amount of deviation. Diplopia fields. With the red and green glasses are being placed in front of the patient's eyes, this test is used to determine the presence and amount of concomitant deviations in the 9 cardinal positions, and to determine the distances of the double images, and marking them on an appropriate chart. The tangent scale. It is a special scale with a fixation light in its center. The patient wears a red glass in front of one eye and indicates the position of the red light on the scale, which is the amount of the deviation. Maddox rod test. This device, consisting of glass rods, produces a vertical or horizontal streak to measure the horizontal and vertical deviation. If the streak does not go through the fixation light, prisms of increasing strength are placed in front of the eye until the streak goes through the fixation light. The amount of prism power required to achieve this goal is a measure of the heterophoria. The Maddox wing test. The amount of the heterophoria in near fixation also may be measured with the Maddox wing test. the heterophotometer, or similar devices, all based on the diplopia principle, and all these tests require that the retinal correspondence be normal. Haploscopic tests. Lancaster red-green test. The patient is equipped with red-green reversible goggles. Two projectors are used, a green projector, handled by the patient, and a red projector, handled by the examiner. If one assumes that correspondence is normal, the two streaks will be separated on the screen by an amount corresponding to the deviation of the visual axis. The Hess screen test. It was popularized, in particular for diagnosing paratic or paralytic conditions in patients with normal correspondence. The patient wears red-green goggles. He sees the red circle with one eye and the green circle with the other, and is instructed to place the two circles over each other. To change fixation, the red-green goggles are reversed. Measurements of the angle of strabismus that are based on image separation with red and green glasses is determined as usual. Measuring with the Major Ambleroscope. This test is also based on the haploscopic principle, and aimed primarily at establishing the sensory state of the patient. Measurement of cyclodeviations. Maddox double rod test. For quantitative determination of a cyclodeviation, red and white Maddox rods are placed in a trial frame, the red before the right eye and the white before the left eye. The direction of the glass rods is aligned with the 90 degrees marks of the trial frame. If orthotropia is present, the white and the red lines will be superimposed. If, for example, the red line appears slanted toward the nose, then excyclotropia of the right eye is present. To measure the angle of the right excyclotropia, the red Maddox rod is then turned until the red line is seen superimposed with the white line. If the red line appears slanted toward the ear, then encyclotropia of the right eye is present. To measure the angle of the right encyclotropia, the red Maddox rod is then turned until the red line is seen superimposed with the white line. Bergolini striated glasses. Like Maddox rods, these glasses produce an image of a white streaks perpendicular to the axis of the striations. The glasses are placed in the trial frame with the axes of striation pointing toward the 90 degrees mark. Like Maddox rods, the angle of the cyclotropia is measured by turning the glasses in the trial frame until fusion occurs. Major Ambleroscope. To test for cyclotropia, the targets positioned in the arms of this instrument are rotated around an axis until there is no more movement of the eye that takes up fixation. The amount of cyclodeviation, expressed in degrees, can be read off the instrument. Measurement of dissociated vertical deviations. In DVD, the cover test reveals that the eye turns upward under the cover. Then, after removal of the cover, the eye makes a slow downward movement accompanied by encycloduction. The translucent occluder of Spielmann is especially useful in the diagnosis of this condition. Versions is observation of the movements of the two eyes in the 9 cardinal directions by having the patient follows a fixation target. Ductions is done by covering one eye and observation of the movements of the other eye in the 9 cardinal directions by having the patient follows a fixation target. Elevation in adduction may occur in overaction of the inferior oblique muscle, paralysis of the contralateral superior rectus muscle, dissociated vertical deviation, Duane retraction syndrome, excyclotropia of the involved eye, and atopic muscle pulleys. Depression of the adducted eye may occur in overaction of the superior oblique muscles, paralysis of the contralateral inferior rectus muscle, atopic muscle pulleys, and Duane retraction syndrome. Measurement of vergences with prisms. The patient is asked to fixate the appropriate object. A rotary prism is then placed in front of one eye. The prism strength is increased. When the patient reports diplopia, the amount of prism power is noted. It represents the patient's fusional amplitude. The near point of convergence, NPC, is determined by placing a fixation object at 30 to 40 centimeters in the midplane of the patient's head. The patient is then asked to maintain fixation on the object. The object is then moved toward the eyes until one of the eyes loses fixation and turns out. The distance at which this occurs is the NPC. After bringing the fixation object into reading distance, ask the patient to maintain convergence after the fixation object is removed. Some patients are able to keep their eyes converged in the absence of a fixation object. When a manifest deviation of the visual axis is present, images of objects are shifted onto the retinas. The larger the shift, the greater the deviation. When fusion became impossible, two distressing results occur. First, different objects are imaged on the two foveae, and therefore are seen in the same visual direction and overlap. This phenomenon is termed confusion. Second, two identical objects are imaged on disparate retinal areas, the fovea of one eye and the peripheral retina of the other eye, and therefore, the two objects are seen in different visual directions, that is, they are seen double. This phenomenon is termed diplopia. Mechanisms to avoid diplopia and confusion are suppression and anomalous retinal correspondence. Suppression is defined as the inhibition of the confusing image originating from the retina of the deviated eye. Anomalous retinal correspondence is binocular sensory fusion of the fovea of the fixating eye and the non-foveal retinal area of the deviated eye to permit a single binocular vision. The most common causes of monocular diplopia are changes in the lens, anomalies of the tear film, the cornea and the vitreous, pressure of the upper lid on the cornea, brain trauma and in cerebrovascular accident. Monocular diplopia disappears when the patient looks through a pinhole. In binocular diplopia, a red glass test will determine its type. In esotropia it is uncrossed or homonymous diplopia. In exotropia it is crossed or heteronymous diplopia. In hypertropia or hypotropia it is vertical diplopia. Finally, in cyclotropia it is torsional diplopia. Suppression may be monocular suppression in uniocular heterotropia, or alternating suppression in alternating heterotropia. Perimetry can be done with any type of haploscopic devices with the use of color differentiation, such as red-green spectacles. This permit monocular and alternating suppression to be detected. In strabismic patients who has monocular fixation, scotomas are found in the deviated eye, but in patients who has alternating fixation, scotomas are found alternately in the two eyes. Perimetry can be done with any type of haploscopic device that allows scanning of the retinas to detect the presence of scotomas. Similar findings were reported by the screen and mirror arrangement of Travers for the mapping of suppression scotomas in strabismus. By using prisms, one can estimate the extent of a suppression scotoma. By placing prisms of increasing strength in front of the eye, one will find a prism with which the patient reports diplopia. Now, the image of the fixation point is thrown out of the region of the suppression scotoma onto a retinal area that is not suppressed. The power of the prism required to produce diplopia is a measure of the extent of the suppression scotoma. A more effective test for foveal suppression is to measure the visual acuity of each eye under binocular conditions with the projecto chart slide. A decrease of visual acuity of one eye that is not present when the eye is tested under monocular conditions will indicate foveal suppression. Suppression can also be diagnosed with the Worth 4-dot test. In normal fusion, the patient sees the all four dots. In normal retinal correspondence, if the patient sees only the three green lights from the left eye, this is right suppression. If he sees only the two red lights from the right eye, this is left suppression, and if he is switching between seeing two red lights or three green lights, this is an alternating suppression. If he sees five lights, the red lights may appear to the right, as in uncrossed diplopia with esotropia, or to the left of the green lights as in crossed diplopia with exotropia. To make a patient aware of the suppressed image of the deviated eye, one must reduce the retinal illuminance of the fixating eye by using red filters ladder until the patient sees double. The greater the number of the filter needed, the deeper the suppression. Patients with 30 to 40 prism diopters of esotropia may make use of the blind spot mechanism to avoid diplopia, by putting the visual image of the deviated eye onto the blind area of the optic disc. The red filter test. In normal retinal correspondence with normal fusion, the patient can see the red and the white image superimposed. Heterotropic patients with a normal retinal correspondence can see two lights, a red one and a white one. In esotropia the images appear in homonymous uncrossed diplopia. In exotropia the images appear in heteronymous crossed diplopia. Patient with anomalous retinal correspondence, single binocular vision occurs in the presence of a manifest strabismus. To distinguish between suppression and anomalous retinal correspondence, a vertical prism is placed base up before the deviated right eye. In the case of suppression the prism will move the white image below and to the right of the red image. In the case of anomalous retinal correspondence, the white image appears directly below the red image. After-image test is performed by using a battery-powered camera flash to produce a vertical afterimage in one eye and a horizontal afterimage in the other eye. The resulting afterimage is that of a line with a break in its middle, which represents the fovea. If the vertical afterimage with its central hole appears to cross the center of the horizontal afterimage, this implies that there is normal retinal correspondence. But, if the vertical afterimage with its central hole appears to the left or to the right of the hole in the horizontal afterimage, this implies that there is anomalous retinal correspondence. Striated glasses of Bugolini. In normal retinal correspondence with normal fusion, the patient can see two streaks crossed in the center. If the patient with manifest deviation reported two streaks crossed in the center, then anomalous retinal correspondence is present. If the patient reported only one streak, then suppression is present. If the patient reported two streaks separate from each other or crossing in the peripheral part of the streaks, then diplopia is present. If the patient reported one line, then the lines switch and they can only see the other line, then an alternating deviation is present. Testing with the Major Ambleroscope. If normal correspondence exists, the images of two dissimilar targets appear to be superimposed. In the presence of anomalous retinal correspondence and if the patient is esotropic, there will be crossed diplopia. If the patient is exotropic, uncrossed diplopia will occur. Strobismic amblopia is always unilateral and is caused by active inhibition of visual input originating in the fovea of the deviating eye. This inhibition is elicited by overlap of the different foveal images transmitted to the visual centers from the retinas of the fixating eye and the deviating eye. Anisotropic amblyopia is caused by active inhibition of the fovea in one eye to eliminate superimposition of a focused and a defocused image originating from the fixation point. Visual deprivation amblyopia, amblyopia occurs in children with congenital or traumatic cataracts, corneal opacities, blepharospasm, surgical lid closure, or unilateral complete ptosis. Amblyopia exanopsia may also be produced in the formerly fixating eye of an amblopic patient after prolonged patching, occlusion amblyopia, or after prolonged unilateral atropinization. Organic amblyopia may exist in patients with organic loss of vision from structural anomalies of the ocular media, retina, or optic nerve. Amblyopia secondary to nystigmus. The effect of abnormal eye movements on visual threshold is significant in patients with nystigmus in its latent and manifest forms. Fixation preference can be detected by the presence of searching nystagmoid movements of the deviated eye when the fixating eye is covered. Fixation preference can also be detected by observing the length of time required for the fixating eye to resume fixation once the cover is removed. If this occurs after a few seconds and before the next blink, a strong fixation preference exists, and the deviated eye is probably amblyopic. From a practical clinical standpoint, a difference of 2 lines on the visual acuity chart is commonly used as a diagnostic criterion for amblyopia. The neural density filters profoundly reduce vision in eyes with central retinal lesions and glaucoma, whereas the vision of eyes with amblyopia was not reduced by such filters. In patients with amblyopia, it is always of interest and importance to compare the vision obtained with visual acuity symbols presented in a row to that obtained with isolated symbols. Patients with amblyopia are capable of discriminating small visual acuity symbols when they are presented singly, but not when presented in a row. In many amblyopic eyes, visual acuity at near fixation has been found to be no better than at distance fixation. The behavior of accommodation in amblyopic eyes. There is reduced accommodative response in amblyopic eyes. There is improved functioning of the amblyopic eye in low luminances. This led to investigation of whether the fixation pattern underwent any changes in scotopic conditions. The fixation area of an amblyopia eye may change with changes in the direction of gaze, usually in the sense that in esotropes fixation becomes more eccentric in abduction and less eccentric in adduction. In eccentric fixation, the patient reports that he looks straight at the object imaged on the non-foveolar retinal area. In eccentric viewing, the patient reports that he is looking past the object that he is asked to fixate. Bilateral eccentric fixation may occur in patients without strabismus and with bilateral central scotomas caused by macular diseases. The size of the receptive fields in amblyopic eyes is determined by the use of the Hermann grid. In normal eyes, pupillomotor sensitivity is highest in the macular area, whereas in amblyopic eyes pupillomotor sensitivity is greater peripherally than centrally. Diagnosis of eccentric fixation could be detected by ophthalmoscopic observation by asking the patient to focus on the visual target. The reaction time was significantly longer when measured through the amblyopic eye than when measured through the normal eye. The reaction time is the time elapsed between the presentation of a sensory stimulus and an associated volitional response. The unsteadiness in fixation is vastly exaggerated in amblyopia. The increased tendency of amblyopic eyes to drift while fixating a stationary visual target was also recorded. It is also confirmed that the pursuit movements in amblyopic eyes are irregular and jerky. Major Ambleroscope. Targets of special interest with differing amounts of disparity, so that they appear at different relative depth distances. The object seen in depth, which has the least disparity, denotes the patient's stereoscopic threshold. If the patient reports that 2 fiducial marks and 2 circles are seen, they cannot be seen concentrically unless they are also seen stereoscopically. In this test a gross stereoscopic pattern representing a housefly is provided to orient the patient and to establish whether there is gross stereopsis. Random dot stereograms are devoid of any monocular clues, and the patient has no way of guessing what the stereofigure is and where it is located on the test plate. Tno Test is based on a similar principle but has the advantage of eliciting quantitative responses without changing the testing distance. This test uses a pair of red-green spectacles and a test booklet. Lang reported a new test based on panographic presentation of a random dot pattern. Glasses are not needed to recognize the stereoscopic images of a star, a car, and a cat embedded in random dots on the test card. The two-pencil test, though somewhat crude, indicates show well a child is able to cope with a simple visual motor task that is at least partially based on intact stereopsis. Refractive accommodative esotropia with normal AC-to-A ratio eyes defined as an esotropia that is restored to orthotropia at all fixation distances and in all gaze positions by optical correction of the underlying hypermetropic refractive error. Most patients with uncorrected hypermetropia will attempt to clear the image blur by increasing accommodative effort that will, in turn, cause excessive accommodative convergence. If fusional divergence is insufficient to compensate for this impulse to converge the eyes and in the presence of a normal or high AC-to-A ratio, esotropia will develop. If fusional divergence amplitudes are sufficient to cope with the induced ESA deviation, an esophoria will be produced. In the presence of a low or flat AC-to-A ratio, the patient may remain orthotropic since the convergence induced by excessive accommodation is normal or even subnormal. Such patients may develop a mild form of pattern deprivation amblyopia or ametropic amblyopia in both eyes. Therapy of refractive accommodative esotropia is full correction of the hypermetropic refractive error determined by cycloplegic refraction. That is usually all that is required initially for rehabilitation. Then, the cycloplegic refraction is repeated annually, and the glasses are adjusted when necessary. If the distance deviation is reduced or eliminated by glasses and esotropia remains at near fixation, then, a non-accommodative convergence excess is present. If the glasses only partially reduce the angle of strabismus at near and distance fixation, then, partially accommodative esotropia is present. The use of LASIK in the treatment of accommodative strabismus is being discussed with increasing frequency. At this stage of our knowledge we are opposed to this treatment in the pediatric age group. Non-refractive accommodative esotropia with high AC-to-A ratio eyes defined as an esotropia greater at near than at distance fixation, unrelated to an uncorrected refractive error. The etiology is closely linked with an abnormal synkinesis between accommodation and accommodative convergence. The effort to accommodate elicits an abnormally high accommodative convergence response. Since the near deviation is the primary obstacle to normal binocular vision in patients with non-refractive accommodative esotropia, the ideal treatment is with bifocal lenses. Hypoaccommodative esotropia is defined as an esotropia greater at near than at distance fixation, unrelated to an uncorrected hypermetropic refractive error and caused by excessive convergence from an increased accommodative effort to overcome a primary or secondary weakness of accommodation. It is characterized by a small refractive error, a remote near point of accommodation, a small deviation at distance fixation, but a large esotropia at near fixation. Anisotropia is partially accommodative when accommodative factors contribute to but do not account for the entire deviation. A residual esotropia may exist despite full correction of a hypermetropic refractive error. Essential infantile esotropia is a manifest esotropia with an onset between birth and 6 months of age. Consistent findings of essential infantile exotropia are large angle more than 30 degrees, initial alternation with crossed fixation, occasionally also very early fixation preference, no clinically apparent CNS involvement, and asymmetrical optokinetic nystigmus. Variable findings of essential infantile exotropia are amblyopia, apparently defective abduction, apparently excessive reduction, up or down shoot on adduction, A or V pattern, DVD, manifest latent nystigmus, manifest nystigmus, and anomalous head posture. Non-accommodative convergence excess esotropia with normal AC-to-A ratio eyes defined as an esotropia that is larger at near than at distance fixation in an optically fully corrected patient whose AC-to-A ratio is normal. Acquired or basic esotropia is a comitant esotropia with a gradual onset after 6 months of age but usually limited to childhood and a near deviation that approximately equals the distance deviation. Esotropia in myopia. There are 2 special forms of esotropia occurring with myopia. The first type is an esotropia with limitation of abduction in both eyes, and normal adduction. The second type is caused by restrictive factors caused by the big size of the globe in high myopia. Acute acquired comitant esotropia may occur after interruption of fusion, which occurs in temporary occlusion of one eye as in treatment of amblyopia, corneal injury, and after excision of a chalazion. Microtropia. Ultrasmall angles of strabismus may escape diagnosis by ordinary methods of examination and are frequently overlooked. The cover test may be negative, or the fixation movement of the deviated eye may be absent or so small that it defies detection by the examiner when the sound eye is covered. Recurrent esotropia is a rare form of esotropia which recurs to the same angle despite multiple operations. Among the factors that could cause such a condition are uncorrected hypermetropia, anomalous retinal correspondence, nystigmus blockage by convergence, or a blind spot syndrome. Sensory esotropia. The most common causes are anisomtropia, injuries, corneal opacities, congenital or traumatic unilateral cataracts, macular lesions, and optic atrophy. Consecutive esotropia occurs almost exclusively iatrogenically after surgical overcorrection of an exodeviation. Exodeviations are classified into the following patterns. 1. Divergence excess exodeviation, in which the exodeviation is at least 15 degrees larger at distance than at near fixation. 2. Basic exodeviation, in which the distance deviation is approximately equal to the near deviation. 3. Convergence insufficiency exodeviation, in which the near deviation is at least 15 degrees greater than the distance deviation. 4. Simulated divergence excess exodeviation, in which the prism and cover test will show an exodeviation that is significantly larger at distance than at near fixation. However, by unilaterally occluding the eyes of such patients for 24 hours reveals the deviation at near fixation, often equal or even exceed that at distance fixation. This test is known as the occlusion test of Skewed. Patients with exophoria commonly complain of eye strain, blurring of vision, difficulties with prolonged periods of reading, headaches, and diplopia. Photophobia occurs commonly in intermittent exodeviations. It has been assumed that when a child is outdoors and looking at infinity, there are no near clues to stimulate convergence and that bright sunlight dazzles the retinas so that fusion is somehow disrupted, causing the deviation to become manifest. These explanations imply that one eye is closed to avoid diplopia and visual confusion. Another less well-known symptom of intermittent exodeviations is microptia. Young patients with an exodeviation may use voluntary convergence to overcome the deviation at near fixation. Therefore, it is advised to measure the angle of strabismus at distance while a patient reads the 6-9 line on the visual acuity chart. In patients with the divergence excess type of exodeviation, a latent strabismus at near fixation often coexists with a manifest strabismus at distance fixation. Thus, normal binocular vision is constantly being reinforced, and sensorial adaptations are infrequent. Consecutive exotropia arises either spontaneously in a formerly esotropic patient or iatrogenically after surgical overcorrection. Spontaneous change from esotropia to exotropia usually can be associated with poor vision of the deviating eye. Sensory exotropia is a condition of unilateral divergence as a sequel to loss of vision or long-standing poor vision in one eye, which was caused by refractive errors, unilateral cataract, aphakia and many retinal and optic nerve lesions. Infantile exotropia is a relatively rare disorder. Onset is before age 6 months where patients are healthy with no evidence of systemic or ocular disease. Truly comitant hypodeviations occur infrequently. To find a patient with a significant vertical deviation of the same magnitude in all positions of gaze with either eye fixating and with the head tilted to either shoulder is indeed unusual. Prisms are ideally suited for relief of the comitant hyperdeviations. They should be distributed evenly before the two eyes, base down before the hypertropic eye, and base up before the hypotropic eye. The prescription should be based on the minimal prismatic power that provides comfortable single binocular vision. Dissociated vertical deviation is among the most intriguing and least understood of all forms of strabismus. Even though the unique clinical features of this anomaly clearly distinguish it from other forms of vertical motor disturbance, the diagnosis may be difficult when associated with other forms of strabismus, especially with sulcovertical deviations. Dissociated horizontal deviations is characterized by intermittent, asymmetrical abduction and elevation of the dissociated eye. Elevation in adduction may be unilateral or bilateral. Upshoot in adduction in its bilateral form is characterized by left hypertropia in dextroversion and right hypertropia in levoversion. It may appear as an isolated phenomenon or occurs with esotropia or exotropia, often associated with a V pattern. Depression in adduction may occur in paresis or paralysis of the ipsilateral inferior oblique muscle, the contralateral inferior rectus muscle, contracture of the contralateral superior rectus muscle. Cyclotropia is caused by an imbalance between the muscle pair producing intuition, the superior oblique and the superior rectus muscles, and the muscle pair producing extusion, the inferior oblique and the inferior rectus muscles. Cyclotropia is associated with paratic or paralytic cyclovertical muscle problems, particularly those caused by dysfunction of the oblique muscles. On the other hand, cyclodeviations also occur in association with DVD, in the A and V patterns of strabismus without an obvious paratic component, in endocrine ophthalmopathy, myasthenia gravis, plagiocephaly, after surgery for retinal detachment, and in heterotopia of the macula, secondary to retinal traction or as iatrogenic cyclodeviations after surgical macular rotation for age-related macular degeneration. Esotropia with V pattern increases in downward gaze and decreases in upward gaze. Exotropia with V pattern increases in upward gaze and decreases in downward gaze. Esotropia with A pattern increases in upward gaze and decreases in downward gaze. exotropia with a pattern increases in downward gaze and decreases in upward gaze. Ex-patent strabismus describe patients who may have essentially no deviation or only a small one in primary position, although exotropia is present in upward and downward gaze. Y-pattern strabismus describe patients who may have exotropia only in upward gaze. Lambda pattern strabismus describe patients who may have exotropia only in downward gaze. When the difference in deviation between upward and downward gaze is 15 degrees or more, a V pattern should be considered as significant vertical incompetence. In V pattern esotropia with elevation in adduction and inferior oblique weakening procedure merely closes the V pattern in upward gaze, and horizontal surgery is done for esotropia as usual. In V pattern esotropia without elevation in adduction, horizontal muscle surgery are done to correct the esotropia as usual, with downward transposition of the medial rectus muscles and upward transposition of the lateral rectus muscles. In V pattern exotropia with elevation in adduction, a weakening procedure on the inferior oblique muscles will decrease the deviation in upward gaze. However, if clinically significant amounts of exodeviation in primary and downward positions of gaze are present, myectomy of the inferior obliques must be combined with horizontal surgery. In V pattern exotropia without elevation in adduction, a horizontal surgery and, if the deviation is of significant magnitude in downward gaze, downward transposition of the medial rectus muscle and upward transposition of the lateral rectus muscle are indicated. In A pattern esotropia with depression in adduction, a bilateral tenectomy or recession of the superior oblique tendon is required. To counteract the predictable increase of the esotropia in downward gaze following superior oblique weakening, it is usual to be combined with horizontal surgery. In A pattern esotropia without depression in adduction, it is necessary to combine recession of the medial rectus muscle and resection of the lateral rectus muscle with upward transposition of the medial rectus and downward transposition of the lateral rectus muscle. In A pattern exotropia with depression in adduction, tenectomy of both superior oblique tendons will lead to a predictable decrease of the deviation in downward gaze. If only a small exodeviation in primary position and upward gaze is present, this procedure may be sufficient. Otherwise, horizontal surgery must also be performed. In A pattern exotropia without depression in adduction, a horizontal surgery with upward transposition of the medial rectus muscle and downward transposition of the lateral rectus muscle must be performed. In Y pattern exotropia with elevation in adduction, a bilateral weakening of the inferior oblique muscles will close the Y pattern in upward gaze and must be combined with an operation on the horizontal rectus muscles to correct the exotropia. In Y pattern exotropia without elevation in adduction, no treatment is necessary when the patient fuses in primary position and downward gaze, has a normal head posture, and does not complain about double vision in upward gaze. When chin elevation is present, surgical weakening of both inferior oblique muscles will close the Y pattern. In lambda pattern exotropia with depression in adduction, patients with a lambda pattern will usually depress the chin to maintain fusion in primary position and upward gaze and to avoid the downward gaze position. A weakening of both superior oblique muscles will close the lambda pattern. Diagnosis of paralytic strabismus of recent onset is not particularly difficult and is based on the presence of a motor deficiency in the field of action of the paralyzed muscle, as in right lateral rectus muscle paralysis or right medial rectus muscle paralysis. The terms paralytic and paralytic often are used interchangeably in clinical ophthalmology, even though paralytic denotes only a partial or incomplete paralysis. Another diagnostic symptom of recent paralytic strabismus is diplopia in the field of action of the paralyzed muscle, as in right lateral rectus muscle paralysis. In paralytic strabismus, the secondary angle of deviation on fixating with the paralyzed eye is greater than the primary angle of deviation on fixating with the sound eye. Paralytic hyperdeviation is more difficult to diagnose because it is necessary to differentiate between a pair of elevators, the superior rectus and the inferior oblique muscles, and a pair of depressors, the inferior rectus and the superior oblique muscles in each eye. In right elevators paralysis, when the patient is fixating with the right paralytic eye, he exerts maximal innervational effort to move the right paralytic eye into primary position. Consequently, according to Herring's law of equal innervation, excess innervations to the yoke elevator muscles of the other eye, causing excessive elevation of the left eye. In a patient with a left superior oblique paralysis who, less than the normal amount of innervation will be required when he is looking up and to the right. Since the innervation flowing to the right normal eye is determined by the left inferior oblique muscle, the right superior rectus will seem paralytic. This is termed as inhibitional palsy of the contralateral antagonist. In right paralytic hyperdeviation, if the hyperdeviation is greatest on left gaze, then the paralyzed muscle is either the right superior oblique muscle or the left superior rectus muscle. If the hyperdeviation is greatest when the head is tilted to the right shoulder, then the paralyzed muscle is the right superior oblique muscle. If the hyperdeviation is greatest when the head is tilted to the left shoulder, then the paralyzed muscle is the left superior rectus muscle. In right paralytic hyperdeviation, if the hyperdeviation is greatest on right gaze, then the paralyzed muscle is either the right inferior rectus muscle or the left inferior oblique muscle. If the hyperdeviation is greatest when the head is tilted to the right shoulder, then the paralyzed muscle is the left inferior oblique muscle. If the hyperdeviation is greatest when the head is tilted to the left shoulder, then the paralyzed muscle is the right inferior rectus muscle. In left paralytic hyperdeviation, if the hyperdeviation is greatest on right gaze, then the paralyzed muscle is either the left superior oblique muscle or the right superior rectus muscle. If the hyperdeviation is greatest when the head is tilted to the left shoulder, then the paralyzed muscle is the left superior oblique muscle. If the hyperdeviation is greatest when the head is tilted to the right shoulder, then the paralyzed muscle is the right superior rectus muscle. If the hyperdeviation is greatest on left gaze, then the paralyzed muscle is either the left inferior rectus muscle or the right inferior oblique muscle. If the hyperdeviation is greatest when the head is tilted to the left shoulder, then the paralyzed muscle is the right inferior oblique muscle. If the hyperdeviation is greatest when the head is tilted to the right shoulder, then the paralyzed muscle is the left inferior rectus muscle. If the patient is asked to point to an object in the field of action of the paralyzed muscle while the sound eye is covered, his finger will point beyond the object toward the field of action of the paralyzed muscle, as in right lateral rectus muscle paralysis. This test is termed as past pointing. The forced duction test is a simple method to differentiate between muscle paralysis and the presence of mechanical restriction of ocular motility. If no resistance is encountered, the motility defect is clearly caused by paralysis. If resistance is encountered, mechanical restrictions do exist. To distinguish lateral rectus or medial rectus muscle paralysis from mechanical restriction, we apply the forceps at the 6 and 12 o'clock positions and move the eye into abduction and adduction. To distinguish superior rectus or inferior rectus muscle paralysis from mechanical restriction, we apply the forceps at the 3 and 9 o'clock positions and move the eye into elevation and depression. The generated muscle force by a contracting muscle can be estimated by stabilizing the eye with forceps while the patient tries to move the eye against this obstacle. This test is used to distinguish muscle paralysis from mechanical restriction. The presence of a tug on the forceps indicates normal contraction of the muscle, then mechanical restriction is present. The absence of a tug on the forceps indicates muscle paralysis. Estimation of saccadic velocity of the eye may be useful in distinguishing between a mechanical and a paratic limitation of ocular motility. If paralysis exists, the velocity of eye movement into the field of action of the paralyzed muscle will be markedly decreased. If the motility defect is caused by a mechanical obstacle, the saccadic velocity of an eye movement into the field of apparent paces will be normal. In isolated paralysis of the superior rectus muscle, the paralyzed eye is hypotropic in primary position. There is limitation of elevation in abduction. Elevation is normal in adduction. There is overaction of the ipsilateral inferior rectus and the contralateral inferior oblique muscles. There is a small excitotropia, and absent Bell's phenomenon. Superior rectus muscle paralysis is frequently associated with weakness of the hemilateral levator palpebrae muscle. Since the upper lid elevates with elevation of the globe and drops when the eye moves downward, a true ptosis caused by elevator weakness must be differentiated from pseudoptosis secondary to the hypotropic position of the globe. The differential diagnosis of a superior rectus muscle paralysis includes mechanical causes that limit elevation of the eye, such as contracture, fibrosis, high myopia or heavy eye, myositis, endocrine orbitopathy, or a blowout fracture of the orbital floor. Whenever elevation is not restricted, the forced duction test will be negative, then paralysis of the superior rectus muscle is present. Whenever elevation is restricted mechanically, the forced duction test will be positive, and the restriction often involves the entire upper field of gaze. Unisolated paralysis of the medial rectus muscle is very rare. With this type of paralysis, the greatest defect of ocular motility occurs when the affected eye moves into adduction. Since the action of the antagonistic lateral rectus muscle is unopposed, Unexotropia usually is present in primary position. The differential diagnosis of an isolated medial rectus paralysis includes internuclear ophthalmoplegia, synergistic divergence and Duane's syndrome. In isolated paralysis of the inferior rectus muscle, the affected eye is hypertropic in primary position with limited depression in abduction and normal depression in adduction. When the patient fixates with the paratic eye, there is hypotropia and pseudoptosis may occur in the sound eye, creating diagnostic difficulties. Unisolated inferior oblique muscle paralysis is the least likely muscle to become paralyzed. In primary position, the affected eye is hypotropic. The greatest deviation occurs when the patient attempts to elevate the adducted paratic eye. Limited elevation in adduction and overaction of the unopposed ipsilateral superior oblique muscle. The differential diagnosis of inferior oblique muscle paralysis is Brown syndrome. Since the defect of ocular motility is clinically similar, both show limitation of elevation of the adducted eye. The forced duction test is necessary in differentiating between Brown syndrome from paralysis of the inferior oblique muscle. The forced duction test is positive in Brown syndrome and negative in inferior oblique muscle paralysis. Vertical muscle paralysis following cataract surgery consists of limitation of elevation or depression with diplopia. This complication is caused by the myotoxic effect of the anesthetic agent or by accidental injection of the muscle belly or the nerve supplying the muscle. When the ocular motor nerve is completely paralyzed, the paralyzed eye will be in a position of abduction, slight depression, and intuition. Concurrent paralysis of the levator palpebrae will cause ptosis of the upper lid. The motility of the affected eye will be limited to abduction, to small degrees of depression in abduction. The intrinsic muscles of the eye also are involved, causing the pupil to be dilated and non-reactive. Aberrant regeneration of the ocular motor nerve fibers may result in failure of the upper lid to follow the eye as it moves downward, causing retraction of the upper lid in downward gaze. This is known as pseudo-Graves' sign. Intraocular nerve paralysis. The affected eye is hypertropic. The hypertropia is greatest in the nasal field of the involved eye. The Boltzkowski head tilt test is diagnostic with increase of the hypertropia on tilting the head to the same side of the involved eye. In bilateral paralysis of the trochlear nerve, there is right hypertropia in left-tenant gaze and a left-tenant hypertropia in right gaze. Positive Boltzkowski head tilt test with the head tilted to either side. Bilateral exotropia and V pattern. The diagnosis of sixth cranial nerve paralysis should not present any difficulties. Esotropia will be present with the fixating eye in primary position. The greatest esotropia occurs on attempts to abduct the paretic eye. Most patients will complain about double vision in lateral gaze and assume a compensatory face turn in the direction of the paralyzed muscle. The differential diagnosis includes the Duane retraction syndrome and, with congenital esotropia, pseudo-abducens paralysis simulated by crossed fixation and the nystigmus blocking syndrome. In bilateral paralysis of the sixth cranial nerve, both eyes may be in a position of adduction with bilateral limited abduction. A benign and often recurrent form of sixth cranial nerve palsy occurs in children, usually following upper respiratory infections or other forms of mild viral illness, immunizations, or impetigo. Mobius syndrome is congenital bilateral abducens paralysis associated with facial diplegia and microglossia. Various degrees of esotropia may be present in primary position and the abducens paralysis may be incomplete or asymmetrical. Skewed deviation is a transient vertical divergence of the eyes, whereby one eye is elevated and the other depressed. It may occur in association with brainstem, cerebellar, or vestibular disease. Upshoot of the adducted eye and downshoot of the abducted eye in skewed deviation may easily be confused with overaction of the oblique muscles. Double elevator paralysis is paralysis of both elevator muscles, the superior rectus and the inferior oblique muscles. When the patient fixates with the non-paretic eye, the paretic eye will take a hypotropic position and the upper lid may be slightly ptotic. Elevation of the paretic eye from any position of gaze is severely restricted, hence the term double elevator palsy. The ductions of the paretic eye are normal in all other positions of gaze. Fixation with the paretic eye will cause a hypertropia of the non-paretic eye, and the pseudoptosis will disappear. The differential diagnosis of double elevator paralysis is restricted elevation of the eye which occurs in blowout fracture of the orbital floor, congenital or acquired fibrosis of the extraocular muscles and endocrine myopathy. Negative forced duction test will confirm the diagnosis of double elevator paralysis. Double depressor paralysis is paralysis of both depressor muscles of one eye, the inferior rectus and the superior oblique. When the non-paretic eye is fixating, the paretic eye is hypertropic in primary position. Ductions are restricted in the entire lower field of gaze and normal in all other gaze positions. Lesions of the supranuclear ocular motor pathways or centers cause bilateral conjugate paralysis of associated muscle groups. Gaze paralyzers may occur in dextroversion, levoversion, elevation, or depression, depending on the site of the lesion. Internuclear ophthalmoplegia is caused by lesions in the medial longitudinal fasciculus. Adduction is limited and an asymmetrical nystigmus is present involving the abducting eye. Duane retraction syndrome. Duane 1 is characterized by narrowing of the palpebral fissure and retraction of the globe on attempt adduction, esotropia or orthotropia, limitation of abduction, normal adduction, and frequently associated with upshoot and downshoot of the adducted eye. Duane 2 is characterized by narrowing of the palpebral fissure and retraction of the globe on attempted adduction, exotropia or orthotropia, limitation of adduction, normal abduction, and frequently associated with upshoot and downshoot of the adducted eye. Duane 3 is characterized by narrowing of the palpebral fissure and retraction of the globe on attempted adduction, esotropia, exotropia or orthotropia, limitation of both abduction and adduction, and frequently associated with upshoot and downshoot of the adducted eye. Brown syndrome is characterized by limitation of elevation of the adducted eye. The clinical picture resembled a paralysis of the inferior oblique muscle, but the forced adduction test showed resistance to elevation of the adducted eye. Adherence syndrome is a developmental anomalies of extraocular muscles in which the sheaths of the lateral rectus and inferior oblique muscles and those of the superior rectus and the superior oblique muscles are adherent. Patients with this syndrome have hypertropia in primary position, restricted elevation, and a positive traction test. Strabismus fixus is a rare condition in which one or both eyes are anchored in a position of extreme adduction, that is convergent strabismus fixus, or in position of extreme abduction, that is divergent strabismus fixus. The involved eye is and cannot be moved, and the forced adduction test will confirm the immobility of the eye. Acquired strabismus fixus has been reported in conjunction with amyloidosis and in patients with high myopia known as myopic strabismus fixus. The cause of strabismus in high myopes is the disproportion between the size of the orbit and the volume of an enlarged or elongated myopic globe. The affected eye is esotropic and shows a generalized restriction of motility in several gaze directions. Forced adduction testing showed mechanical restriction of ocular motility in all peripheral gaze positions. Congenital fibrosis of the extraocular muscles is characterized by downward fixation of one or both eyes, marked ptosis, chin elevation and perverted convergence movements on attempts to look upward or to either side. Graves' ophthalmopathy is an autoimmune inflammatory disease that may cause limitation of ocular motility, most commonly a restriction of elevation, and limitation of abduction. Graves' ophthalmopathy is caused by myopathy of the medial and superior rectus, respectively. The lateral rectus muscle is least commonly involved. Acute orbital myositis belongs to a subgroup of nonspecific orbital pseudotumors, and its etiology remains obscure, although immunologic mechanisms have been postulated. Limitation of ocular motility is a common finding and may consist of restriction of abductions in the field of action of the involved muscle. Cyclic heterotropia is a rare form of strabismus. Apparently depends on a regular clock mechanism that usually follows a 48-hour rhythm, that is, a 24-hour period of normal binocular vision is followed by 24 hours of manifest heterotropia. Acquired motor fusion deficiency is absence of fusional convergence, divergence or both. It occurs after closed head trauma, cerebrovascular accident, intracranial tumors, and after brain surgery. In blowout fracture of the orbital floor, orbital contents such as fat, fascia, the inferior rectus and oblique muscles may prolapse into the maxillary antrum, or part of these tissues may become incarcerated in the fracture site. Marked limitation of eye movements, particularly elevation, depression, or both, are common findings. The forced adduction test will demonstrate limitation of elevation. In fracture of the medial orbital wall, abduction will be limited or even absent. The forced duction test showed that the eye could not be moved at all by passive force. Superior oblique myocymia is an episodic nystagmoid intuition and depression of one eye. There is high frequency and low amplitude torsional and vertical oscillations of the affected eye during an attack. Ocular myasthenia gravis is an acquired autoimmune disease, affecting the neuromuscular junction in which the number of acetylcholine receptors is decreased. Ptosis is asymmetrical, unilateral or bilateral. The motility disturbances may affect any or all of the extraocular muscles. Coogan's lid sign is a helpful diagnostic. After rapidly and repeatedly looking from downward gaze into the primary position, the upper lids will elevate excessively for a brief moment and may twitch several times. Chronic progressive external ophthalmoplegia is a rare progressive disorder that affects bilateral ocular motility and the levator palpebrae muscle. It is characterized by bilateral ptosis and decreasing motility of the eyes in all directions of gaze. Convergence insufficiency is caused by uncorrected high hypermetropia or myopia. Patients with hypermetropia exceeding, say, 5 diopters or 6 diopters, make little or no efforts to accommodate, and in those with myopia there is no need to accommodate to obtain clear vision at near fixation. Convergence insufficiency may also occur after wearing a bifocal prescription in the beginning of presbyopia. The diagnosis of convergence insufficiency is based on the finding of a remote near point of convergence and decreased fusional convergence at near fixation. Exophoria at near fixation is present in patients with convergence insufficiency. Therapy of convergence insufficiency is orthoptics, prisms basin or surgical by bimedial rectus resection. In convergence paralysis, although adduction is normal, the patient is unable to converge. Accommodation may be normal, reduced, or absent, and the pupil may or may not be involved. In some patients the pupillary reflex may be abolished for convergence and retained for light, reversed Argyll-Robertson pupil. In convergence spasm on asking the patient to fixate an object held closely before the eyes. After the fixation object has been removed, the eyes will remain in a convergent position. Therapy consists of prolonged atropinization of the eyes and plus lenses prescribed as lower segment bifocals. Divergence insufficiency is characterized by intermittent or constant esotropia at distance fixation with symptomatic uncrossed diplopia in patients who maintain fusion at near. Fusional divergence is reduced markedly both at distance and near fixation. Divergence insufficiency may be corrected by base-out prisms. Divergence paralysis is based on the following criteria: uncrossed diplopia at distance fixation, the angle of strabismus remains unchanged on lateroversion. When an object is brought nearer to the patient, the two images approach each other and are finally fused when the object is at a distance of 25 to 40 centimeters from the patient. Congenital nystigmus is an involuntary, rhythmic, pendular, or jerky conjugate oscillation of the eyes and occurs in a manifest and a latent form. Common causes of manifest congenital nystigmus are congenital cataracts, congenital glaucoma, aniridia, achromatopsia, Down syndrome, and high myopia, optic nerve hypoplasia, Leber's amaurosis, and oculocutaneous albinism. Sensory defect nystigmus is caused by inadequate image formation on the fovea as a result of anterior visual pathway disease. Sensory defect nystigmus is always bilateral and horizontal and often is of the pendular type in which the eyes oscillate with equal velocity in both directions. Motor defect nystigmus is caused by a defect in the efferent mechanism, possibly involving the centers or pathways for conjugate ocular motor control. Spasmus nutans is a small amplitude, high frequency, horizontal nystigmus in one or both eyes that is accompanied by head nodding. Spasmus nutans may be associated with optic nerve and chiasm gliomas, empty cellar syndrome, or a porencephalic cyst. Congenital nystigmus is characterized by a slow drift of the visual target off the fovea, followed by a rapid saccadic correction movement. Manifest nystigmus usually occurs with equal amplitude and frequency regardless of whether both eyes are open or one eye is closed. In manifest latent nystigmus, the nystigmus intensifies upon occlusion of one eye. In manifest nystigmus, it is necessary to determine visual acuity by covering either eye and with both eyes open. Binocular acuity is higher than monocular acuity when a superimposed latent nystigmus is present. In nystagmic patients, visual acuity at near fixation is dramatically better than at distance fixation. Some patients with manifest congenital nystigmus are able to decrease the amplitude or frequency of the nystigmus by superimposed vergence or version innervation, known as dampening or blocking. Blocking or blockage has been defined as an innervational impulse to bring one or both eyes toward a position that can reduce or suppress the innervational impulse causing the nystagmus. The decrease of the nystagmus by adduction or convergence may be etiologically significant in causing esotropia and introduce the term nystagmus blockage syndrome. Maintaining the eyes in a peripheral gaze position by sustained innervation of yoke muscles involved in lateral, vertical, or oblique gaze causes dampening of the nystagmus. Visual acuity usually improves with the eyes in this peripheral gaze position that termed as null point, and therefore, the head shows anomalous head posture. The head may be turned to either side, tilted toward one shoulder, or the chin may be elevated or depressed depending on the position of the null point. The combination of infantile exotropia with latent or manifest latent nystagmus has become known as the Chanchas Syndrome.